Hello and welcome to this issue of the Center for Podiatric Education period. In this session, we'd like to discuss the subject of skin disorders in the diabetic patient. And I guess I do have an overall theme to this session, and that is that we as podiatric physicians need to be more involved in the recognition of skin disorders in our diabetic patients and the evaluation and treatment of those skin disorders. And I think this should be a big part of our practices. I think that we simply don't do enough of this and need to be more involved. In looking at the subject of skin disorders in the diabetic patient, the real question I pose is, what is your job as a podiatric physician? And I would argue that we have established a significant position with reference to the diabetic patient. And our job is to try as best we can to reduce the incidence of amputation in the diabetic patient and secondarily improve quality of life. This could include, for example, reduction of pain from neuropathy. What does that entail? It entails educating patients regarding risk factors that they have for ulceration, infection, and amputation. It means that we as physicians have to recognize these risk factors and take on actively managing these risk factors, evaluating patients and making appropriate adjustments in their therapy, whether if they're responding appropriately or not. So what is our job? And I think it's not at all an easy one. I think as podiatric physicians, we have to look at these patients, evaluate dermatologic disorders, both diabetes and non-diabetes related. We want to evaluate patients for the presence of vascular disease and make appropriate referrals. And by vascular disease, by the way, I'm including here also venous and lymphatic disorders, reduction of edema, for example, which is a risk factor. We want to look at patients for the presence of asymptomatic as well as evaluation and treatment of symptomatic neuropathy, both or including autonomic, sensory, as well as motor neuropathy. We want to recognize deformities which are present and make appropriate recommendations for accommodation or surgery when necessary. We want to look for biomechanical abnormalities. We want to evaluate patients for gait abnormalities, and we certainly want to make recommendations regarding appropriate footwear. So there's more to treating the diabetic patient's foot than onychomycosis. I think that if this is the extent of your evaluation and treatment of diabetic patients, that you're missing a wonderful opportunity to reduce the risk for infection, ulceration, amputation. I think the majority of these problems, which are quite common, are neglected. They tend to be underdiagnosed and undertreated. And we know, again, that these are associated with significant potential complications in the diabetic patient. There is every reason for you as a podiatric physician to get involved in the evaluation and treatment of skin disorders in these patients. The incidence of foot pathology in the diabetic foot is extremely high. It's at least 50%. In some studies, in other studies, almost as much as 100%. And we have various types of skin disorders in the diabetic patient. We have some that are associated either weakly or strongly with diabetes, such as ulceration, diabetic bulla, necrobiosis, diabetic dermopathy. We have increased incidence of infections, including fungal and bacterial infections, as well as candidal infections. We have the manifestations of diabetic neuropathy, as well as manifestations in the skin of diabetic vascular disease, and occasionally we have skin reactions to topical or systemic medications. There's a significant list of skin disorders that occur with increased frequency in the diabetic patient. This includes vasomotor and pseudomotor changes of the skin, which are important to recognize and treat because they predispose the patient to infection and injury. We have idiopathic bullae of diabetes, which not infrequently is associated with ulceration and staphylococcal or streptococcal infection. We have more classic skin disorders such as necrobiosis or diabetic dermopathy. We have an increased risk of other problems such as skin pruritus and cirrhosis in the diabetic skin. We have, of course, ulceration, and then other problems which are seen in diabetic skin with increased frequency, although not all that commonly, such as digital sclerosis, granuloma annulare, xanthomatosis. So when you walk in that room with the diabetic patient, I think particularly important is the first examination, the first time that patient presents for an evaluation. They may say, I was referred by my primary care physician because I'm diabetic and I need my toenails cut or some such thing, or I need diabetic shoes. But that does not dictate what you as a physician should be doing. Your job is to let the patient know that you are there to identify risk factors and to educate that patient regarding those risk factors and to modify those risk factors as best you can to reduce the likelihood of an infection or ulceration. So to some extent, you can choose to see what you wish to see and act accordingly. So there should be more to evaluation and treatment of the diabetic patient than just shoes and nail care. The majority of these patients have vascular or neurologic or musculoskeletal or biomechanical or other issues that pose a distinct risk to their limb preservation and really should be evaluated and treated by you. And I think the best time to do this is that first visit, so that the patient receives a complete examination, a complete assessment of their risk factors, and then is educated as to what was found and what needs to be done. So the reduction of lower extremity amputation and ulceration certainly depends on control of diabetes, and I certainly discuss this with my patients, but recognition and early treatment before there is significant morbidity is probably the most important thing. Once we initiate therapy for various problems, it is important to recall on subsequent visits what it is we've diagnosed and what it is that we are doing to treat those problems, and whether or not the patient is responding appropriately, and if not, what modifications in therapy are being recommended. The extent and type of diabetes is important regarding the types of problems we see. There are regional variations. A good example would be patients who live in hot, more moist, humid climates where we see more fungal infections, for example. Variables for the extent of the disease and the rapidity and significance of these diseases at presentation are dependent in part on the extent of neuropathy, such as motor neuropathy, sensory and autonomic neuropathy, the extent of vascular disease. For example, with autonomic neuropathy, we see frequently loss of sweat function, predisposing the patient to fungal infections and predisposing the patient to pathology associated with dry skin. And then other comorbid conditions, for example, congestive heart failure and edema, or the patient with chronic kidney disease. These are comorbid conditions that also are going to play a role in modifying the nature and extent of the pathology that we see in these patients. The pathophysiology, as you would imagine, with regard to diabetic skin, correlates with the extent of glycemic control. We have the effects of advanced glycosylation end products on skin proteins and other proteins. We have inhibition of keratinocyte proliferation and migration and protein production, and as a result, you have significant pathology developing in that skin. We have increased death of skin cells. We have reduced production of nitric oxide, as a result of which we have decreased vasodilation and decreased vascular perfusion to skin, to wounds, to nerves. And we know that the effects of diabetes include an immune suppression with impaired phagocytosis, impaired chemotaxis, so that when confronted with infectious changes and inflammatory changes. We have impaired ability to respond. All of this taken together, again, contributes to the increased incidence of skin disorders, which we see in our patients with diabetes. An example is seen here, the rather typical ulcerating pinch callus at the hallux interphalangeal joint, and you see how dry this skin is. We get that typical dry callus, that dry, scaly, fissured skin, and these are changes that we see with autonomic neuropathy. With vasomotor and pseudomotor changes, we have skin that is less tolerant of pressure. It is less elastic due to the alteration in skin proteins from the advanced glycosylation end products effects on the skin proteins. We may have some additional mechanical issues such as hyperextension of the interphalangeal joint or a hallux limitus or a bunion. Perhaps additionally pronatory forces which are placing increased pressure in this area, and this area less able to tolerate that pressure due to the effects of the diabetes on the skin. And we commonly see ulceration in the hallux interphalangeal joint, plantar great toe, and plantar first and second metatarsal heads, as well as the heels. And interestingly enough, the effects of autonomic neuropathy on the skin are most often presented in these same areas, so that there has been a suggestion that perhaps we're not looking hard enough at the effects of autonomic neuropathy on the skin changes that we see. We know that autonomic neuropathy is one of the first manifestations of diabetic peripheral neuropathy. Frequently, our diabetic patients present with small fiber neuropathy, neuropathy affecting the unmyelinated or smaller, minimally myelinated nerves, and not infrequently, loss of sweat function is one of the first manifestations of diabetic neuropathy. And we can see, for example, by doing a simple punch biopsy, 3 millimeter punch biopsy, we can look at innervation of the sweat glands. And you could see in the central portion to your right a normally innervated sweat gland, and below to your right we see lack of innervation of the sweat gland due to autonomic neuropathy. This translates clinically into dry skin, and it's probably one of the major factors that contributes to our knowledge that diabetic skin in the foot is frequently very dry, and one of the reasons that we are not uncommonly referring patients for various lotions and creams and ointments or gels for better hydration of their skin, decreased transepidermal water loss, and so forth. So not only do I treat these patients locally in trying to find appropriate therapy for their skin changes, but I also consider at times efforts to improve function of the autonomic nervous system if I can. So we see patients that come in with this dry skin. At times, as the patient on the right, they have sort of a pinkish hue, so that these patients have a delayed capillary filling even though they have excellent pulses, and that's because they have vasomotor instability with dry, scaly, fissuring skin. We get these buildup of dry calluses in rather typical pressure locations, and together with a number of other factors that have to be evaluated, we know that at least in part some of these skin changes are occurring secondary to diabetic autonomic neuropathy. Looking at the relationship of autonomic neuropathy to some commonly encountered problems, for example, this particular study looked at diabetic patients with probable fungal infections of the foot. Now, in this particular study, a neuropad was utilized, and you can see a neuropad on one of my patients off to the picture on the right. Neuropad is a device that can be utilized to assess sweat function, and in looking at risk factors associated with fungal infections in the foot, impaired pseudomotor activity, that is to say alteration in peripheral autonomic nervous system function, was present in 60+% of the patients. We also have the effects of advanced glycosylation end products, which alter protein properties when we have the non-enzymatic glycosylation of the proteins in our bodies due to elevated glucose levels. In this case, we're speaking more specifically about skin proteins. When we have the glycosylation of skin proteins, particularly collagen, we lose flexibility, solubility, and the collagen becomes more rigid. We have less yielding fibrotic skin, and we have more rapid aging of the skin. We also have the effects of advanced glycosylation end products on our immune system, again with impaired leukocyte function, and we have impairment in the production and quality of growth factors that are produced. So these changes in the diabetic skin result in increased susceptibility to injury, and there's increased transepidermal water loss, as a result of which we have a drier skin, more easily susceptible to, made more susceptible to fungal and bacterial infections. The skin becomes drier, blistering becomes easier to occur. And we do have a variety of topical agents that we attempt to utilize to reduce transepidermal water loss and improve the protective barrier. With these skin changes that occur in our diabetic patients, we also see reduced immune function, so that transient and resident bacteria, which are normally normal skin flora, become pathogens, so that vigilance is required to look for these early manifestations of infection. So this loss of barrier function, both in terms of effects on skin dryness as well as increased susceptibility to infection, becomes a very important factor to assess and treat in our patients with diabetes. The clinical correlations of this loss of barrier function include tinea infections, bacterial infections such as cellulitis and erysipelas, and in worst case scenarios, necrotizing infections that are present. So we need aggressive therapy. We have impaired immune function of the skin with our diabetic patients getting these fungal infections and bacterial infections. We have reduced thickness of the skin. We have decreased ability of the skin to resist pressure, and we have decreased collagen production, and abnormalities in collagen which is present. The most common disorders that we see are listed here, and you can see that there is tremendous variability in the reported incidence of these problems, but certainly infection of the skin, skin xerosis, and limited joint mobility are very commonly reported issues in the diabetic patients, and these are issues that we need again to recognize and address clinically in our practices. Some quick examples of the importance of some relatively minor problems. Here a patient with onychomycosis who had pressure against the thickened nail, and in the presence of vascular disease ends up with a gangrenous toe, and we all know this opens up a world of potential complications depending on what other comorbid conditions are present. So if we look at cellulitis in the diabetic patient, many of the factors that are present that contribute to cellulitis and predispose patients to cellulitis are modifiable by us. We have the ability to recognize and treat skin xerosis, to recognize and treat tinea pedis, to recognize and treat vascular disease, to reduce edema in these patients, so that instead of waiting and being reactive, we certainly have the ability as podiatric physicians to look at these patients, identify these factors, talk to the patients and their family about the risks that these factors pose, and then initiate appropriate therapy. Another study looking at the prediction of foot ulceration in patients with diabetes, and here again a number of factors that are modifiable by us. We can certainly identify and treat tinea pedis. We can aggressively identify and treat onychomycosis. We can identify the presence of neuropathy. In terms of a history of prior ulceration and amputation, we can initiate appropriate mechanical therapy in an effort to offload those areas of the foot that are now predisposed to transfer ulceration and so forth. So these again are factors that we can identify and initiate in a proactive manner therapies to try to prevent feet from coming into our office and looking like this. In this day and age, a diabetic patient should not be presenting to the office of any healthcare provider with feet that look like this. Simply not acceptable. Again, looking at risk factors for a severe infection and osteomyelitis, tinea pedis, onychomycosis, and interdigital tinea pedis have been recognized as potential risk factors, and these are again modifiable factors. Looking at this particular study in the relationship of fungal infection and ulceration, again the identification of fungal infection as a risk factor for ulceration is well established, and the authors calling for increased treatment of that fungus infection present in the diabetic patient to reduce the risks of ulceration. More commonly seen skin changes in the diabetic patient include skin xerosis, tinea pedis, nail deformities. Another study looking at a summary, if you will, a meta-analysis of papers demonstrating that with regard to the diabetic foot, there is a clear link between tinea pedis, onychomycosis, and cellulitis. And as in other papers, the authors calling for improved surveillance and treatment of tinea pedis and onychomycosis. And I would call attention to the word treatment, and this is, I think, the critical portion of what we need to change in our paradigms. This was the classic study of Jeffrey Robbins looking at the relationship of onychomycosis to secondary foot infections, gangrene, and foot ulceration without gangrene in patients with diabetes, showing a clear relationship between patients with onychomycosis and those that developed serious limb-threatening diabetic foot infection. So what you do depends really on what you wish to do. If your practice is running in, cutting toenails, selling shoes once a year, then so be it. That is your practice, but that is not risk reduction, and it certainly is not affording the patient the best opportunity to reduce the incidence of amputation and serious pathology. In looking at various skin lesions, one always has the option of doing a biopsy. If it is an inflammatory lesion, you look at the area with the most advanced inflammatory changes, and that is where you would perform your biopsy. If it's a bullous lesion, then you want to probably biopsy some of the newer lesions. Ask and try to ascertain which lesions have been present less than 48 hours. Whenever possible, excising an entire lesion is helpful. You certainly want to avoid crusts, erosions, fissures, and excoriations. And for non-bullous lesions, usually a biopsy between 1 and 4 millimeters in the center of the lesion, or excise the entire lesion. For the larger lesions, the most abnormal looking and thickest part generally would be representative of the best areas to obtain a biopsy. Now, I just want to say a word about the 25 modifier. The 25 modifier is usually attached to an additional service performed on the same day. For example, the patient may be coming in every 10 or 12 weeks for debridement of their toenails or some pressure calluses or some type of thing. But if you get involved, as you should, in evaluating and treating the majority of your patients for associated pathology to reduce the incidence of infection, ulceration, amputation, and so forth, then you're going to be actively evaluating and treating these things. You need to add an office visit to that visit for routine foot care, so that your notes should clearly indicate that you are evaluating and treating a significantly separately identifiable pathology on the same day as a procedure or other service, meaning that you're submitting a nail code for debridement, but you're also evaluating and treating a separate problem. And in my opinion, this is the most important modifier for the primary care podiatrist, because you're going to be very much involved in assessing these patients and treating them. It saves the patient the need to have to come back for an additional visit. There's no reason why particularly our older diabetic patients have to come back for a separate visit. You want to remember that the service must be significant and it must be medically necessary. Minor problems do not warrant the 25 modifier. So generally, this would be a problem that requires a prescription or would require the patient to normally have to return to the office. Now, you also want to recall that you're going to be following up with these patients to evaluate response to treatment, the presence or absence of adverse reaction to the treatment. For example, you may be concurrently treating symptomatic diabetic neuropathy. You may be concurrently treating their peripheral arterial disease, so that if you prescribe a topical or if you prescribe a oral medication or some other therapy, perhaps you wrote for physical therapy, when the patient returns, it's important that you document how they have responded to that therapy, any potential side effects, and what modifications in therapy you're recommending. So you want to remember that that evaluation and management service has to be a separate problem, distinct from other services, and at times some people have recommended separate documentation for the EM visit. I don't think that that's an issue. One recommendation I would make from a personal standpoint is to get away from pre-populated notes. If you are indeed actively treating these patients, I think it's best to dictate an individualized note for the most part, particularly for the E&M visit. E&M visits with the 25 modifier are provided the same day as other procedures. When you bill, you attach the 25 modifier to the EM code, to the EM code with the diagnosis. Make sure that your EM level of billing is reflected in the documentation, and this should include the time for counseling and coordinating chronic care with the patient and the family, or coordinating home care. And we are very involved in doing this with these older patients. They're frequently brought to our offices by children, relatives of various types, some responsible party for their health. We take the time to counsel these patients, and it's critical that you document appropriately. So let's talk clinically about some of these problems now. Pruritus. This is not an uncommon complaint of patients with diabetes. And as far as your differential diagnosis for pruritus goes, this can be due to candidal infections. It can be secondary to skin xerosis. It can be due to a fungal infection, which may not be clinically overt. You want to remember that pruritus can be a manifestation of neuropathy. And if you are unable to account for the pruritic symptoms secondary to a skin disorder, consider initiating therapy or biopsying for the presence of neuropathy as a potential cause of pruritus. And you may end up, for example, prescribing a medication that's typically utilized to treat neuropathy rather than a dermatologic agent. You want to make sure you're familiar with any types of lotions or creams or ointments that the patient's applying to their foot. They may have a contact allergy to one of these medications, and pruritus can be a manifestation of atherosclerosis. Tinea pedis is common in our diabetic patients. It should be evaluated and it should be treated. We want to remember that in the presence of hyperglycemia, we have immune suppression, we have increased incidence of fungal as well as candidal infections. Other predisposing factors to fungal infections include the presence of vascular disease as well as autonomic skin changes, pseudomotor changes. Tinea pedis has shown to be common in the patient with diabetes. The most common misdiagnosis is dry skin, so that we have patients that may or may not be symptomatic. They are using various types of emollients or humectants or various skin products for their dry skin, when in fact what they're demonstrating is manifestations of a fungal infection. Over half these patients have an associated pseudomotor deficit from autonomic neuropathy, and studies have called for more aggressive diagnostic and therapeutic and preventive care. So you should be seeking out the presence of tinea pedis, perhaps doing appropriate laboratory studies, utilizing appropriate topical and or systemic therapy as you see fit, and this should be something that is an increased part of your practice. Onychomycosis is a major part of the podiatry practice in primary care, particularly in patients caring for the diabetic patient. And there is no question that nails such as this are a major risk factor for pressure, secondary infections, cellulitis, and legs are lost. If we look at the presence of ulceration and foot ulceration in patients with and without onychomycosis, studies have shown a significantly higher rate of gangrene and foot ulceration in patients with onychomycosis. The majority of patients have T. rubrum as the infecting organism. We do see other organisms present, and if we are going to actively treat these patients, meaning doing more than just cutting or reducing the nail thickness, but actually trying to rid the patient of the fungal infection, then we may want to consider appropriate identification of the organisms. You want to remember that onychomycosis may be superimposed on other problems, perhaps repeated impaction of the nail into the shoe from ill-fitting shoes, perhaps a hallux extension deformity at the interphalangeal joint, or some other problems. A variety of techniques are available for the diagnosis of onychomycosis, and the question is, what testing should you do? Well, we do know that there are a large number of disorders which can present clinically as appearing similar to onychomycosis, so that if we're going to actively treat, testing will be part of the differential diagnosis. Some of the newer therapies need to be appropriately applied. You want to remember that some of the new topicals in particular are extremely expensive. They've only been tested for lesser degrees of infection, and therefore when you have serious and advanced disease, probably they are not appropriate for treating these patients, although we really have no data to suggest they are or are not effective. But to justify the cost of medications that cost several $100s a month, it would be good, I think, medicine to go ahead and obtain appropriate studies to confirm, A, that it is a fungus, and B, that it is a fungus likely to be responsive to the expensive topical therapies. We also know that some therapies are associated with potential mortality or morbidity, particularly systemic treatment of onychomycosis. Therefore, we probably want to go ahead and obtain appropriate culturing to justify the use of those medications. So we do want to remember that speciation may be important. In looking at the most common test available to us, KOH will tell you yes or no you have a fungus, but it does not tell you the genus and species. Therefore, a KOH is acceptable if the only information you need is yes or no, is there a fungus. You don't need to speciate if you're using non-specific therapy. PAS is helpful in terms of its significant sensitivity to the presence of a fungus. It is an excellent test if it's negative in eliminating the presence of a fungus. But here again, PAS provides no speciation or evidence regarding the viability of the organisms. Fungal cultures will identify the genus and species. Probably is going to be extremely helpful when expensive therapies are being utilized, or there's consideration for systemic therapy, because we want to confirm that there is a fungus, and we want to also confirm the fungus that we're going to be treating is going to be susceptible to the therapy we're utilizing. And then, of course, there is genetic testing and rapid genetic testing, which is also available. It's been suggested that one can utilize lasers for treatment of onychomycosis in the patient with diabetes. Well, we want to keep in mind that onychomycosis is known to be associated with increased risk of ulceration, amputation, and gangrene. Therefore, in the diabetic patient, we want to actively treat the onychomycosis. Now, the problem is that there is no evidence that lasers actually treat the onychomycosis. They are FDA approved for the temporary clearance or improvement of the appearance of the nail. And when you utilize lasers in the diabetic patient, you are denying them actual treatment for the fungus, because we really have no evidence that's going to be curative. At best, you get a temporary clearing of the nail. You're denying the patient access to treatment. There's the potential for injury, and the FDA does not recommend the use of lasers in, quote, special populations. This would include the patients with vascular disease, the diabetic patient, as well as the immunosuppressed patient, patients with a history of recurring cellulitis who should be receiving active treatment for the onychomycosis, and patients with lymphedema. We also want to treat the tinea pedis, which is frequently present concurrently with the onychomycosis. We have various presentations of tinea pedis. We have interdigital tinea pedis. We have T. rubrum, less commonly T. pentagrophytes. We have blistering types of tinea pedis. We have dry keratotic types of tinea pedis. So we want to look and state and examine these patients and determine how much drying or moisturizing is necessary. In the web spaces of our diabetic patients, we want to remember that there is a differential diagnosis. This would include Corynebacterium minutissimum infections or erythrasma. We may have primary tinea pedis or candida infections, erosio interdigitalis. We may have gram-positive or gram-negative infections between the toes, and we may have dermatophytosis complex, where we have an initial fungal infection and then secondary bacterial infections. We also want to remember that there are some primary skin disorders that can occur in the interdigital spaces. So these toe web space infections can become extremely important in the diabetic patient. They can lead to very serious pathology when unattended, particularly in the presence of vascular disease, the immunosuppressed patient, and the patient with neuropathy who cannot recognize the signs and symptoms. So in treating interdigital space infections, we want to consider both bacterial and fungal cultures, various drying techniques, antibiotic therapy as appropriate for either the Corynebacteria or mixed infections. Oftentimes staphylococcal pseudomonal infections are present here. You may want to consider antifungal, anti-yeast therapy. So this is going to be driven by your examination, your history, and culture results. And over the years, I've seen a number of patients who have developed limb-threatening infections from what started out to be just an interdigital tinea pedis infection. Both the patients to your left ended up with amputations of their limbs as a result of what began as simple web space infections. Heel fissuring is seen in the patients with diabetes. Again, this is one of the most common locations for autonomic neuropathy-associated skin changes. We have xerosis with fissuring and scaling. We want to remember that tinea pedis may also present in a similar manner. We may have comorbid conditions with skin xerosis together with tinea pedis. There is a differential diagnosis for heel fissuring. In the diabetic patient, this can result in ulceration and infection. The treatment is dependent upon your diagnosis and what you see as contributing factors to the infection itself. Diabetic dermopathy is seen in a substantial number of patients in our practices. It's more an entity that is non-threatening, but one where the patients want to know what are these spots that I'm getting on the front of my legs, where we have these flat, non-painful, non-pruritic, hyperpigmented macules. They tend to be seen more in the older diabetic patient, more frequently in patients with neuropathy, retinopathy, and nephropathy. The cause is really unclear. They're frequently referred to as diabetic shin spots. They will start as these flat red or brownish macules or papules. They're somewhat atrophic, and they're typically oval or round. They're typically bilateral, although not symmetrical. They're really not symptomatic. The cause is unknown. There's really not a whole lot of effective therapies. Some have suggested dietary supplementation with zinc is helpful. Others have suggested better controlled diabetes is helpful. Necrobiosis lipoidica is classically presenting, as you see in this particular patient, as a well-demarcated, waxy-looking plaque with a violaceous rim. And this violaceous rim that you can see about the lesion is rather typical. You frequently see this waxy, shiny appearance to the surface of the lesion. If you look carefully, you see some telangiectasia. And what you're looking at here with that hyperpigmented margin, that violaceous rim, the telangiectasia, the shiny appearance is rather classic for necrobiosis lipoidica. Now, some of these lesions do ulcerate, as you see here. And when ulcerated, they do require biopsy because they can progress to squamous cell carcinoma. It is a condition in which we have atrophy of the epidermis, so that you're seeing more of the dermis. The dermis becomes more granulomatous. It is thought to be associated with deterioration of the collagen. And again, when they are ulcerated, again, such as this lesion, where again you see this macular lesion, papular lesion. You see a violaceous, well-defined rim, telangiectasia, but what you see here also is ulceration. This requires biopsy to rule out squamous cell carcinoma. Out of an abundance of precaution, one should obtain arterial studies before proceeding with biopsy. There are a number of therapies that are available for the treatment of necrobiosis lipoidica. This can include steroids, either topically or site-injected or systemically. There are some authors who feel that patoxyphylline is helpful for the resolution of these lesions. And you can see that a variety of alternatives are certainly available depending on the nature and extent of these lesions, and again, ruling out the presence of a squamous cell carcinoma. Diabetic bulli are not at all uncommon. The cause of diabetic bulli remain unclear. It is seen more commonly in patients with renal dysfunction. Scarring is rare, but superficial ulceration and infection are not rare, and frequently staph or strep infection will occur in association with these lesions. More commonly, they heal in about a month and a half. They present in a variety of locations in the lower extremity. They can look rather infected, and my own personal experience has been that many of these lesions end up with underlying ulcerations, as are exhibited in these examples. Sometimes there is a secondary cellulitis associated with this, and anti-staphylococcal and streptococcal therapy is indicated. Treatment includes aspiration for culture and cytology. Biopsy can be obtained to rule out more serious blistering diseases, pemphigus, pemphigoid, for example. In general, the lesions are left intact. Prophylactic antibiotics to cover staph and strep, and monitoring for ulceration, which is not at all uncommon. Granuloma annulare is seen with some increased frequency in the diabetic foot. You see these sharply defined, well-defined lesions, far less commonly on the foot than other areas. These are treated with topical steroids, and a rather typical example of granuloma annulare with typical pathologic findings on biopsy. Vitiligo, not rare in the patient with diabetes, particularly type 2. This is treated with topical steroids, and there are other therapies available for that. So in summary, we know that diabetes is associated with a variety of skin disorders. Some of these are unique to diabetes, some are found with increased frequency or varying frequency in the patient with diabetes. Your job as a podiatric physician is to identify these patients, educate these patients, and intervene. And this means that you probably should be using that 25 modifier a great deal more than you are. Not to reduce this to a practice management issue, but the fact is that your job is to identify and treat these various disorders, particularly fungal and bacterial infections. You want to make more liberal use of skin biopsy and culture whenever the diagnosis is in question. And you want to remember that active treatment of these patients with their skin disorders will lower the risk of ulceration, infection, and amputation. So that this is the thing that we're trying to prevent. So I thank you for joining us at the Center for Podiatric Education, and hopefully this has been an educational experience for you. Thank you.